So welcome all to the today's session. So today we will have some session about contraception. Actually, this is FSRH guidelines, that is Faculty of Sexual Health and Reproduction Guidelines, and Reproductive Health Guidelines. And the today's session is about barrier methods of contraception and STI prevention. After that, we will talk about combined hormonal contraception, and then we will talk about IUCDs because there can be questions on this. Okay, so we start with barrier methods. So in barrier methods we have male condoms, we have female condoms, diaphragms, cervical caps, and dams. Okay, so male condoms, with they are made up of latex or non-latex material or deep proteinized latex varieties. What you have, the diaphragm and the cap. Okay, so these diaphragms and cap, generally they ask you some question, SBA type of question. So these diaphragm or the cap, they must be left in situ for at least 6 hours. Okay, so after the last episode of intercourse, this particular method, the diaphragm or cap should be there in place for 6 hours. Okay, and sperm in the lower reproductive tract are unlikely to be alive after 6 hours. Latex diaphragms can remain in situ for 30 hours. So generally they ask you for how much duration you need to keep. So minimum 6 hours you need to keep. Then maximum for how much duration you will keep. So if it is a latex, then it is 30 hours. If it is a silicone cervical cap, then you can keep it for 48 hours maximum. But because this is a foreign body, if you keep it in for longer time, there will be chance of infection. Okay, sepsis or the toxic shock syndrome, what specifically if at all we want to talk. So that is why for the longer duration it is not advisable, but for minimum it should be there for 6 hours. So this is the duration they can ask you. Okay, so minimum 6 hours it should be in place. If it is a latex, maximum it can stay there for 30 hours. If it is a silicone cervical cap, then it can stay for 48 hours. Otherwise, the condoms, the barrier, they are use and throw. Okay, but if it is a cap or the diaphragm, it should be in place minimum for 6 hours. Then diaphragm or cervical cap can be inserted with spermicide at any time before intercourse. Spermicide should be reapplied if sex is to take place and the diaphragm or cap has been in situ for more than 3 hours, or if the sex is repeated with the method in place. So you need to apply this spermicidal jelly once again if it is in place for more than 3 hours. Okay, so if the diaphragm or the cap is in place for more than 3 hours and the sex is to be repeated, the spermicidal jelly will be required. Okay, so a diaphragm or cervical cap should not be removed until at least 6 hours after the last episode of intercourse. So these are the SBAs which can be asked on this. This slide is going to be important because they can ask you the failure rate of various barrier contraceptives. Okay, so let's see about the male condom and the female condom first. So this they have described the typical use and the perfect use. What is the meaning of perfect use? Perfect use, the way it should be used ideally. Okay, that means the technique as described, the way it should be used. If it is used in that particular way, there will be minimum failure rate. But what happens in practice, that the human being always makes some errors while using the method of contraception. Okay, so because of that, the failure rate increases. That is called as typical use. Okay, suppose if it is a oral contraceptive, the person may that lady may forget to take the pill. So there will be instruction which are to be how it is to be taken. But if they are not exactly followed the way they are supposed to follow, then that failure rate is called as typical use. Okay, and the perfect is the ideal one. Okay, if the person follows the same method whatever is described and still there is a failure, that will be called as a perfect use failure. Okay, so that is less. Okay, so for male condom it is 2 per 1000. Okay, 2%, and here it is 18%. Okay, here it is 2% and here it is 18%. For female condom it is 5% and it is 21%. Okay, then spermicides it is 18% and this is 28%. Okay, and for diaphragm it is 6 and 12. 6 for perfect use and for typical use it is 12. Okay, so this 2, 18 you should remember for male condom. For female condoms 5 and 21. Okay, sometimes they can ask you the efficacy. So efficacy will be 95% and 5% failure rate. Here it will be 98% efficacy and 2% failure rate if it is perfectly used. Okay, and here it will be 18% failure rate. Okay, here it will be 21% failure rate. Then spermicide alone, if it is used, with perfect use it is 18% failure rate. With typical use it is 28% failure rate. For diaphragm, failure rate is 6, and with typical it is 12. Okay. Okay. So male condoms are 98% effective and female condoms are 95% effective, that we have just discussed. But for that it should be used consistently and correctly. That is the way it should be used. Okay. Pregnancy rates are similar for latex and non-latex condoms. When used consistently, correctly with spermicide, diaphragms and cervical caps are estimated to be between 92 to 96% effective in preventing the pregnancy. So if your diaphragms and caps along with the spermicides they are used, then the success rate will be 92 to 96%. However, if they are used separately, then diaphragm will have the failure rate of 6 under perfect and 12 under the typical use. Okay. And this is the risk of HIV transmission following the sexual exposure to known HIV positive individual. So if the person is HIV positive individual and with that there is a sexual intercourse, then what is the risk of transmission? Okay. So remember, the anal intercourse has got a higher chance of transmission, while the vaginal intercourse has got a lesser chance of intercourse. Okay. So in that also, whether it is a receptive type of anal intercourse or whether it is a insertive type of intercourse. Okay. So you can have a receptive anal, you can have a receptive vaginal, you can have an insertive anal, and you can have an insertive vaginal. Okay. So these figures may look complicated, but just try to understand that the anal intercourse will have a higher rate of transmission. Okay. So if it is a receptive anal intercourse with a non-HIV positive person, then it is 1.1%. Okay. So anal intercourse receptive 1.1%, then followed by receptive vaginal, that is 0.1%. Okay. So it is 10 times less. So vaginal has got less, anal has got more. So if it is a receptive anal, 1.1%, and if it is a receptive vaginal, then it is 0.1%. Okay. Then if it is a insertive anal intercourse, then 0.06%, and if it is an insertive vaginal intercourse, that is 0.082%. Okay. So they are almost similar, 0.06 and 0.08. Okay. So these two you can remember, this receptive and anal as well as vaginal. So receptive anal has got higher 1.11%, receptive vaginal is 0.1%. Okay. Then coming to the STI prevention. Okay. So main role of this barrier contraceptive is in the prevention of the sexual transmitted infection. So chlamydia trachomatis can be transmitted in the vaginal or seminal fluids through vaginal, oral, and anal intercourse. Prevalence of infection in partners of those diagnosed with chlamydia is up to 75%. So this can also be asked because chlamydia gets easily transmitted to the other partner. Okay. So what is the prevalence of chlamydia in the partner? Okay. It is 75% chance that the partner will get affected. Okay. So if the index case is positive and with that person there is a intercourse by the other person who is negative, there is a 75% chance the partner will get affected. Okay. So if you get an index case and you trace the partner of that person, there is a 75% chance that the partner will also be positive. Okay. The consistent and correct use of male or female condom is recommended to reduce the risk of chlamydia transmission. Okay. So that is why when you give the treatment for chlamydia, the use of contraception is very, very important. Okay. For women living with HIV or at risk of HIV infection, the use of either diaphragm or cervical cap is UK MAC category 3. Okay. There is a medical eligibility criteria for the use of contraception, and they are divided into UK MEC. They are called as UK MEC 1, 2, 3, and 4. Okay. So category 3 is where the harm is more than the benefits. Okay. So for women living with HIV or at risk of HIV infection, the use of either. So their diaphragm and cervical cap are MEC3, but you can go ahead with the condoms. Okay. So women with sensitivity to latex proteins should avoid the use of latex barrier contraceptives and may use silicone diaphragm, cervical cap, non-latex male or female condoms, and deproteinized latex male condoms. Okay. So if there is a sensitivity to latex proteins, then the latex barrier contraceptives are to be avoided, and other like a silicone diaphragm or cervical cap, they can be used, or non-latex male or female condoms can be used. For women with history of toxic shock syndrome that we have just discussed before, the use of diaphragm or cervical cap or the contraceptive sponge is UK MEC category 3. Okay. So you should remember these UK MEC categories because they can ask you this in the SBA. So they'll give you the use of this diaphragm or cervical cap or the sponge. Remember, these they should be in place for certain time. So whatever is kept for a longer duration, there is a risk of infection. That is why if there is a history of toxic shock syndrome, then this becomes UK MEC category 3. Okay. Category 1, there is no restriction on use. Category 2, the use can be permissible. Okay. But the risk is still there, which is less. Okay. That we will go into the definitions later. Okay. Women with history of toxic shock syndrome may use male or female condoms because they don't have to stay for longer. They are use and throw. Okay. So I hope these concepts are clear to you. Okay. So this is the thing of UK MEC category. So if you see the category of the diaphragms and the condoms for various conditions. Okay. So condoms are always category 1 in all cases. Okay. High risk for HIV, complicated valvular and congenital heart disease. Okay. Uh, Case of AIDS, history of toxic shock syndrome. Condoms are always 1. Only condition where the condoms are contraindicated or they become category 3 are if there is a sensitivity to latex proteins. Okay. This applies to latex condoms and the diaphragms only. Okay. So if there is a sensitivity to latex proteins, they become UK MEC category 3, while the diaphragms will be in most cases either category 2 or category 3. Okay. If it is a complicated valvular and congenital heart disease, it is category 2, while high risk of HIV infected, not on using antiretroviral or using antiretroviral, it is category 3. AIDS, it is category 3. History of toxic shock syndrome, it is category 3. So these all cases, the diaphragms are category 3. Okay. Then Paris woman and urinary tract infection, the diaphragm and caps are category 2, while sensitivity is category 3 for both. Okay. So these UK MEC category, and it's easy to remember because condoms are category 1 for almost everything except sensitivity to latex proteins. Then these diaphragms and caps will be category 3 for high risk of HIV infected, not taking treatment, then AIDS cases and toxic shock syndrome. Okay. And other cases like what happens in Paris woman, there may be misfitting of the diaphragm and the caps. That is why it is category 2. Okay. Urinary tract infections, I don't know why, but they have put into category 2, and complicated valvular congenital heart disease, then it will be category 2 for diaphragms and caps. Okay. So that finishes the topic of barrier contraceptive and the STI prevention.